it is Elizabeth here again, also known as Nurse Zabe, here on YouTube and Instagram, and I am a labor and delivery and a postpartum nurse and a certified childbirth educator. And so I wanted to go ahead and make a video for you guys that I've kind of been looking back on my videos over the past 8 months or so and just realized that this one is lacking. And so I have a whole series on like unmedicated birth and should you get an epidural, but I didn't make a video for moms who want to get an epidural or who want more education specifically about getting an epidural. So this is going to be 10 things your labor nurse wants you to know about getting an epidural. Basically what an epidural is a medication that is given into the epidural space around the spinal column to create pain relief for your labor and delivery, and then your repair as well if you are needing a repair afterwards. And so the epidural is going to be your best form of pain relief, your most complete form of pain relief if you are seeking pain relief during your labor process. I definitely have said this already, but just to reiterate, your epidural cannot run out. It can... it can't run out because you got it too early, is what I want to say. Obviously, like, there's a certain amount of medication that can run out and then we change it and give you more, but it's not going to run out from getting too early. A lot of people, as they get further dilated and as the baby descends a little bit further, will start to feel a little bit more, and that is a great opportunity if you've got that little patient controlled button to press that button, or to have your nurse call the anesthesiologist back up and have them give you more medication through your epidural. Sometimes you might feel like it's running out, but really what's happening is that the baby has moved down in your birth canal, which is what we want to happen, and things are getting a little bit more painful. The epidural anesthesia, I'm going to stand up real fast. Epidurals work really well from right here to right here. Okay, so sometimes as baby gets lower, we have a little bit more discomfort and we deal with that accordingly. But your epidural is not going to run out. Important distinction about epidurals: they don't run out. That's not a thing. Sometimes they need a little bit of help controlling pain as it gets more intense, but they shouldn't run out. So you don't have to worry about getting an epidural too early because it's going to run out. Getting an epidural and the timing of getting an epidural is really going to depend on your doctor and depend on what your hospital's policy and procedures are as far as being admitted to a labor room from a triage room. Now, with all that being said, it's a really good conversation to have in the office with your doctor. If you are planning on getting an epidural, what is the time frame for me to get an epidural? And it's also really important that you understand that there's going to be a period of time where you are going to be uncomfortable and it's not going to be appropriate yet for you to get an epidural, especially if it's your first baby. That latent phase of labor can take a little while with your first baby, and it's really important for you to be upright and moving and changing positions to help make room for baby. Sometimes the latent phase of labor can last a long time and have a lot of starts and stops and kind of prodromal, and once we give you that epidural, we're kind of locked and loaded into having a baby, and so then you're going to have lots more interventions, a cascade effect that might lead to a poorer outcome. So being up and moving and delaying that epidural until you're in active labor is going to be important for the most part. And obviously we have different caveats and different things that might affect you getting an epidural earlier in the labor process, but just kind of being aware that yes, there is going to be a period of time when you're uncomfortable before you get an epidural. There are other medications that you can do, and it's going to be different based on your facility. A lot of places have like IV narcotics that you can do before you get an epidural. Nitrous is a big thing in the UK. Other parts of Europe, it's coming over to America. But neither one of these things are going to take the pain away like an epidural does. Both of them are going to be a really good distractor from the pain. I always tell people it's like you've had a couple of margaritas. You're still aware that you're having contractions, but you're able to not focus on them so much and breathe through them a little bit better. And okay, so it's an appropriate time for you to get an epidural. and you're going to have to need some lab work to be drawn beforehand. Typically that gets drawn when you get admitted to labor and delivery. They're going to be checking your platelets when they draw your blood. Kind of the rule of thumb is that you can't get an epidural unless your platelets are over 100, and that's not a big deal for most people. Most people's platelets run well over 100. Sometimes there can be thrombocytopenia, which just means low platelets associated with pregnancy, and sometimes you don't find that out till you get to the hospital. It's nothing that I would stress about, but that's what they're checking. Some anesthesiologists give you a little bit of wiggle room under 100, but they don't want to go too much lower because when the catheter comes out of your back, they don't want there to be bleeding, and that's why they check your platelet. And the place is saline lock. You do have to have a saline lock or an IV if you are getting an epidural, and that is because the epidural can sometimes drop your blood pressure. We need an IV in order to give you fluids before the epidural, which can help the blood pressure not drop, and also to give supportive medications to bring your blood pressure up if it does drop. So you'll need to have an IV. Once you decide that you want the epidural, the nurse will contact your provider, anesthesiologist, kind of get that whole ball rolling. Now, one thing that is important to remember is not all hospitals are going to have anesthesiologists in-house. If you're at a teaching facility, you probably will have an anesthesiologist in-house, but if you're at more of a small rural hospital, you might not always have one in-house. They could be up to 30 minutes away. So something to kind of keep in mind when you're thinking, okay, I'm gonna want an epidural soon, maybe letting your nurse know a little bit sooner rather than later if you know that the anesthesiologist is not in-house. Then, once you're ready, and your nurse might have you get up and go use the bathroom too if you're able to do that, but if you're beyond that point, that's okay too. You will assume the position when the anesthesiologist gets in there after signing your consents and all that stuff. So I'm going to show you what the positions look like over on the couch. It's me. I'm back. We're sitting on the edge of my couch now. Hold on. Okay, we're ready. Okay, so most of the time for epidural placement, you're going to be seated in an upright position. Some doctors might have you lie down and curl around baby on your side, but for the most part, we do an upright seated position for placement. So picture this is the bed. The anesthesiologist is going to be standing behind you, back there, right? That makes sense. Sterile, right? So your hair is probably going to be up in a hair tie out of the way. You might get to wear one of those fancy little lunch lady hats to keep your hair out of the sterile environment that the anesthesiologist is working in behind you. So the positions that we're going to assume, the reason why I got this little soccer ball here is because they're harder to do when you're pregnant. So I really want to give you guys a good example of what I'm doing. This is me sitting with really good, strong posture, right? But when you get an epidural, what we're trying to do is this lower part of your back down here is where the epidural is going to go in. I want you guys to be feeling that lower part of your back and see how the bones are really close together. Now lean forward and slump and you can feel how the bones are separating. The anesthesiologist needs you to be in that slumped over position because that is how they are going to best get into those epidural spaces in between the vertebrae. So you're going to be seated all the way back so that the back of your knees are touching the bed. And then I normally have the support person seated in front, and so that you can have your feet up on their chair, up on their knees where they're seated. That way they can't visualize anything that's happening behind you because we don't really want anybody fainting, but then they also can be there kind of holding your legs, holding your hands in support. So you have your legs nice and open, my knees are apart. That gives this belly a space to go. And then I'm going to practice my very worst posture, drop my shoulders, curl in, and curl around this baby. Hands are in my lap, in between my legs. And as you can see, this lower part of my back is really, really, really sticking out, okay? That's what we're trying to do. This is gonna be standing in front of you, helping to support your shoulders, helping you stay in that really good position, and verbally working through your contractions. Hugging a pillow can help you round that back out and push out that lower back. That might be something that they ask you to do. Another thing one doctor really likes us to do is have our patients sit crisscross applesauce and assume that position. again, you're kind of like a shrimp or a scared cat, and really just like reach back there and feel and kind of understand what you're doing right now before you're going in to get your epidural. You're opening up that lower part of your back. And that is going to give the doctor ample place to work. Oh, I'm really glad I don't carry like this. This would be very uncomfortable. Give birth real fast. Okay, now we're back from seeing the positions. That was fun. I gave birth to a soccer ball. While you're in that position, I just want to kind of walk through everything that you're going to be feeling, right? Because you're not going to be able to see behind you, which is kind of nice because you don't really want to be able to see what they're doing. Typically, the father of the baby stays in, and I always have him seated, like I was talking about, in front of mom, and she has her feet on his knees. That way, he can really be a focal point for her, and he also can't see what's going on. Both things that I like because I don't like passing out when we get epidurals. I've only had it happen like twice, and both times it was not fun. So let's avoid that if we can. So, steps of getting an epidural. You've gotten in that really good position that we've talked about. The anesthesiologist is going to clean off your back. That's going to feel cold and scratchy. They're going to put up a nice little shower curtain on your back to keep everything nice and sterile back there. Then they're going to be feeling and poking around. It is your natural inclination when somebody is poking on your back to draw up away from them. Why are you poking on my back? But I want you to really curl into that poke and be like, you poke me, I'm a hit you with my back right back. Because if you stay in that nice good curl up position, they are going to have the best and easiest job of getting in the epidural. So you stay in that nice curled up position, they're going to be doing a lot of poking. Now the part of the epidural that actively is painful is getting the lidocaine. That's going to feel like a big old giant huge bee sting. Here's my personal feelings on this, but getting the epidural when you're in labor, when you get that lidocaine bee sting, it is nothing compared to contractions, but it is a very big stinging sensation. That should fade, and then after that you should just feel pressure. Now it is a lot of pressure sometimes, but it shouldn't be painful, and if it is actively sharp and painful, and not pressure, but sharp pain, then let them know, and they can always give you more of the numbing medication. The anesthesiologist is going to insert a needle into your back, into that epidural space, and then a catheter will be inserted through the needle, and the sharpness of the needle will be taken out, and then the anesthesiologist will be able to program a pump that will continually infuse medication. Often the medication is a numbing medication and a narcotic mixed together. This medication is going to be given continuously on a pump. And often there's also a patient-controlled portion of this analgesia where it basically you have like a little Jeopardy button, and when the light turns green you can press the button and give yourself additional boluses of medication. And that's if you notice that pain is starting to creep up for whatever reason. When you get your epidural, and once you're nice and comfortable, the nurse will make sure that your bladder is being empty. That might be by intermittently putting a catheter in your bladder, draining your bladder and taking it out, or by placing a Foley catheter that will remain in your bladder until very close to delivery. And that just is dependent on hospital policy. So things that are super normal to feel with your epidural, we talked about those contractions feeling a little bit shorter and then not really feeling them. Your legs are going to feel like they're asleep. Sometimes you're still able to move them great, and sometimes you can't move them at all. It's a really weird sensation. My very favorite epidurals are when people are still very mobile but don't feel pain. But you don't always get those epidurals. Every epidural is going to be a little bit different, and every epidural in between different pregnancies is even going to be a little bit different. When you're getting your epidural, we are going to be monitoring your pulse and your blood pressure. I've talked a lot about how getting an epidural can drop your blood pressure. We also monitor your pulse to make sure that the epidural catheter is in the right area. The anesthesiologist, when they're putting in the epidural catheter, they do it by feel. And so basically they have sterile water that they're like injecting in, and eventually it just goes in really nice and easily. Once they feel that they're in the right spot, then they do a test dose where they are asking you, do you hear ringing in your ears, numbness or tingling around your mouth, or your feet suddenly getting numb? We're watching out for those things because that can show us that maybe we're having a more systemic effect of the epidural rather than one that's just in that epidural space. We're also monitoring your pulse, make sure that that doesn't all of a sudden skyrocket, or your blood pressure doesn't all of a sudden bottom out. All of those things would be things that we were looking for not to happen. And if they do happen, we deal with them. After that, the anesthesiologist knows it's in the right spot, get everything taped up, and then we'll get you back in the bed, help you bring your legs up, and then we're going to have you laying pretty flat with a little bit of a tilt, just because we know laying totally flat when you are pregnant is not going to be ideal, and seated up a little bit. But the reason why is that the epidural is very gravity dependent. So if we have you sitting all the way up, your butt is just gonna get super, super numb. We want the epidural to kind of place nicely. So I let people kind of sit in that semi-Fowler's tilted over to one side position for 30 minutes or so until contractions are not painful anymore. What you're gonna notice at first is that the contractions are gonna feel a little bit shorter. You're really just only feeling the peak, and then eventually you're not gonna hopefully be feeling them at all. That is the goal. You might still feel, oh, I'm having some tightening, but they shouldn't be painful. And if they are painful, then that's something that the anesthesiologist can come back and address for sure. Let's go ahead and real quickly talk about side effects. I'm just going to talk about the really common ones, the ones that we see very often, the ones that are not something that I would be super concerned about when seeing. But obviously that we do need to be treating. So the very biggest side effect is that getting an epidural can drop your blood pressure. When your blood pressure drops, your baby gets less blood flow than they're used to, and they often can have corresponding drops in their heart rate that need to be treated. We can treat both of these with ephedrine and phenylephrine. Depending on what your anesthesiologist orders, we go by their orders. You might sometimes feel a drop in blood pressure before it happens. You feel like nauseated, like you're gonna pass out, like your vision is just closing in. Definitely, if you feel any of those things, let your nurse know. Sometimes your baby feels the effects of your blood pressure dropping before it actually drops too. So sometimes baby will have a dip in his or her heart rate, and then we check your blood pressure again and it's low, and we go ahead and treat. Very, very rarely we're unable to treat those things, and an emergency C-section would be necessary if we are unable to keep your blood pressure at a level baby is able to tolerate the blood pressure. Another side effect that we see is shaking. So the hormonal shifts with labor can make you shake. The epidural can also make you shake. Sometimes a warm blanket kind of helps, even though you're not shaking because you're cold. The very best thing that you can do, honestly, is just try to not focus on the shaking, because if you focus on the shaking, you just shake more. Thinking about the shaking does not make the shaking go away. Itching is another normal side effect. It's not an allergic reaction to the epidural. Your nurse can give you some cold rags, lotion, things to get you a little bit more comfortable with that itching. Hey guys, it's future editing Elizabeth here. I just realized I forgot to talk about spinal headaches, which can also be a side effect of having spinal or epidural anesthesia. And basically you just have a headache from puncture that they did with the needle. It happens in about 1% of epidural placements, and it can be treated with fluids, caffeine, or a blood patch. Pushing. This is something I want to talk about. Epidurals, the studies show that they do not increase your labor, but they can increase by about 30 minutes the second stage of labor, which is that pushing. The nice thing with an epidural is that we can labor down a little bit, which means we don't need to start pushing when you are fully dilated immediately, and we can let your body do a little bit of that work for us to decrease your overall length of pushing time. But sometimes it can be really hard to get the hang of pushing when you can't really feel what's going on. In those cases, especially if you just are like really, really heavy-legged and feeling nothing, we can turn down or turn off your epidural. And by we, I mean the anesthesiologist would do those things. Or we could wait until the baby is a little bit lower in the birth canal and triggering that pushing reflex that we have. 2/3 of women get epidurals and they're able to deliver vaginally. So it's not like you can't push. It can just make pushing more difficult, and it can take a little bit longer for that, ooh, I need to push, figuring out how to push thing to click in your brain. Let's talk about when epidurals don't work, because sometimes they don't, and it's super frustrating. So the epidural, like I said, the anesthesiologist is putting it in through feel. The epidural needle is formed in such a way that the catheter should be pointed slightly up, but sometimes it could be pointed slightly down, slightly to one side or the other. And this also just depends on how your anatomy is too, because everybody's anatomy is a little bit different. But sometimes if it's not in the perfect position and direction, or your anatomy is funky, you might be left with an epidural that isn't fully covering your contraction pain, or you have a hot spot. So you have a spot on one side or the other where you still can feel everything. I had this with May, and I honestly think that that was worse than not having an epidural, because it's like a tease of feeling okay and your legs are still really heavy, but you're not feeling totally comfortable. There's a few different things that the anesthesiologist can do at this point, and this is where they just all really shine. But they might need to give you some more medication. They might need to pull the catheter back a little bit, do a little bit of adjusting, or they might just need to start over and replace the epidural to get you that pain relief that you are so desperately after at this point. And it's not because the anesthesiologist doesn't know how to do their job. It's not because you moved. It's not because of anything. It's just one of those things that sometimes happens, and it sucks so badly. But sometimes replacing the epidural is the very best thing that you can do to be comfortable. The last and most important thing that I want all of you mamas to know about getting an epidural is that if you get an epidural, you are not a failure. You didn't fail. You didn't give up. You didn't get overpowered by the pain. You used the tools that were provided for you to make the best decision for you at the time to safely deliver your baby. Epidurals are wonderful tools. Sometimes they're needed to help your body relax and to help you dilate if you're having a hard time relaxing through the contractions, which, let's be real, is not the easiest thing to do in the world. I want all of you mamas to know that you are not failures, you did not give up, you did an amazing thing, and you gave birth to a child. Be it unmedicated in the woods somewhere, or with an epidural or a C-section, however you gave birth to your baby, you are an amazing mother. Thank you guys so much for watching. Definitely like, comment, subscribe, all that YouTube nonsense, and I will see you guys soon. Bye.